typical hospitalization and follow-up. And I would agree with Dr. Kapil that it is good for discrepancies up to 5 centimeters. However, there is a problem with, especially with the congenital limb shortenings. So I think one can combine the limb lengthening on the ipsilateral side with the shortening on the contralateral side. So that's my viewpoint about this. And I think if we can have a debate about this, or we have a consensus, we can.
Thank you, Dr. Gupta. As usual, diplomatic as ever, we can do both. It's open for questions. The floor is, any questions from the floor for all the speakers in the last session?
The debate. I just wanted to pick up one point that you focused on is loss of schooling time.
Yeah.
And I just elaborate on that a little bit. I just gave a talk on 700 lengthenings. It was in Hall F with 7 people in the audience. And this is highly reflective of the stepchild treatment given in general to limb lengthening. And your aspect about loss of schooling is because most surgeons to whom the child comes to with a leg length discrepancy tell them to wait until they are much older. And that's when they reach their 8th and 9th or 10th grades, when schooling is so very important. So the point that I would like to make is, you see, I'm not going to perform a highly skilled spine surgery. Similarly, it is better to have a child who has a leg length discrepancy approach a qualified surgeon. And my prayer to all of you is, for a deserving child, when you know that a girl, whatever the discrepancy is at the age of 3 is going to double at maturity, and in a boy, whatever is the discrepancy at age 4 is going to double at maturity, you can ask them to start lengthening early rather than later and mitigate many of the problems that are seen with limb lengthening. Thank you.
Dr. Milind, I fully agree with you, but I'll tell you my viewpoint that I do start lengthening at an early stage. I do lengthenings. The question is that when you ask the child or the parents to send the child to school with the apparatus on, I tell them, you send the child to school. Most of the times, it is the school which refuses the child. They say, oh no, somebody is going to, tamper with the apparatus or whatever. I've had this problem not once. I've had this problem n number of times. So there lies the problem. Otherwise, yes, I would actually like the child to go to school even with the apparatus. Second thing, I fully agree. If limb length equalization has to be done, it should start very early when you have all the predictors for limb length discrepancy at skeletal maturity. Yes. I don't know what's in your yeah. Yeah, I think I'm not disagreeing with you. I do lengthenings. I think the contralateral limb shortening should be basically a good procedure for small amount of limb length discrepancies, where let's say after unilateral DDH, let's say, you have done a shortening on one side and that shortening is not recovering. So perhaps it's a little more wise to do a contralateral limb shortening in that. You've done about 2 centimeters of shortening in the femur for a DDH. That shortening persists, perhaps that's one indication. And others are about a length discrepancy of less than 5 centimeters. These are some of the indications. Personally, I don't have too great experience with the contralateral limb shortenings, if you ask me honestly.
Now, one sec, Dr. Das.
How many? That's what I'm admitting. I don't have too much experience. I have more experience with lengthenings.
I think going by the quantum of published literature, both of you question, as of now, quantum of published literature, whether people have resorted more to the lengthening of the short limb or shortening of the normal limb. What does the literature, majority of the publications are on the lengthening rather than on the shortening. But one thing as the time is evolving, as clubfoot now we are adopting more and more pauncity, the morbidity factor associated with the lengthening of the affected limb cannot be ignored in totality. because we cannot afford to lengthen the femur by 3 inch and make the knee stiff for lifetime. That cannot be. So, if something can be done in a less morbid way, we have to keep our mind definitely open to receive it rather than this.
If I may just add, that's the very precise reason why we should start lengthening early, so that the temptation to do a lot of lengthening in one stage is not there. So once you realize
having worked in the rehabilitation center for the last 30 years, Milind, I know how many patients we have received with the stiffness of the knees, dislocation of the hips, dislocations of the ankles during the course of the lengthening. So that's why I say, I'm saying majority of the publication as on today are for the lengthening, but as the time is evolving, the gross morbidity sometimes that is associated because of the wrong application, whatever may be the reason. If you take that into account, I think shortening is
like to add one small comment that if lengthening is done by Dr. Milind Chaudhary, it's good.
Yes,
but if lengthening is done by a person who is not trained for, Ilizarov system,
I think
perhaps disasters can be.
We'll draw a line with this so that the next session is not delayed. But that's the true nature of the debate, because Dr. Gupta is an accomplished lengthening surgeon and he's asked to kind of talk about shortening. That's the whole idea. So it doesn't mean that he is for shortening or anything like that. He's well known all over as an accomplished limb lengthening person. These are all these things. So it's just to put, nobody is holding a brief for a particular view. It is to generate discussion. Thank you. Thanks everyone.
अच्छा, अगर किसी को ऊपर नीचे करना हो थोड़ा जल्दी बताना हो प्रेजेंट करना हो। इधर भी चलेगा,
चेक कर लेता हूँ इधर डायरेक्ट चला जाएगा। Good afternoon. We are already running late, so for convenience, I'll just confirm Dr. Saurabh Agrawal.
Is there any?
Dr. Saurabh Agrawal. Dr. Tarun Bali. Dr. Sumit. Dr. Arpit. And Dr. Parvez. Right. So for the present we have 3 speakers and we are already late. How many slides have been audiovisuals?
Excuse me?
How many slides have been loaded? नहीं पहले बोलो मदन
अंकित राहुल ये है सर राहुल है इसमें लिखा सर इसमें लिखा
Good afternoon everybody. I thank the organizers for giving me an opportunity to present my observation on management of displaced ACL avulsion fractures. With the increased incidence of these injuries due to increased sports activity and road traffic accident, every orthopedic surgeon needs to be geared to manage this. Large number of different implants like fiber wires, staples, intra-articular screws have been described for this injury. Most of these have difficulties in the form of intra-articular loosening and a retrieval procedure becomes necessary. I present preliminary observations of a prospective study in which 8 patients were included where a retrograde application of 4 mm partially threaded cancellous screw helps in the fixation of these injuries, particularly in selected cases. ACL has a wide area of attachment to the tibial eminence, including the anterior horns of the medial and lateral meniscus, intermeniscal ligament. These structures can get incorporated in the fracture and cause difficulties in the treatment of this type of injury. Depending on the force and the direction of the force, there can be following types of injuries. All the cases in our study was type 2 and type 3, and type 2, type 3 are amenable to this type of treatment. In type 4, the smaller fragments are excised and the bigger fragment is fixed. ACL avulsion fracture along with condylar fractures present a different category which needs to be managed in a slightly different manner. All the cases in this study was operated within 5 days. Associated injuries were medial meniscus tear in 2 patients, condylar fracture in 1 patient. Minimum follow-up has been done up to 1 year. 2 patients underwent removal of the implants. Immediate swelling, inability to walk is a constant feature in most of these injuries. Though CT would delineate the size and the number of the fragments, MRI is helpful in assessing soft tissue injuries. Cannulated 4 mm system along with the ACL system is kept for the procedure. Both the portals are used. Initially, the fragment would come in the way of the visualization. Fragment is thoroughly lavaged and shaver curette is used to freshen the fragment, prepare the bed, and through the ACL jig it is reduced and temporarily fixed with K-wire. The jig is moved slightly to put one more K-wire or guide wire to fix the fragment in position. Gentle drilling is done with the possibility of risk of comminution in mind. The distance from the tip of the fragment to the anteromedial cortex of the tibia is most important, which describes the length of the screw needed. Usually 30 to 40 mm screws have been found to be adequate. In large fragments, 2 screws could be used. The condylar fracture and the meniscal fragment treatment has to be completed first before going on to the fixation of the ACL fragment. This is type 3 injury managed with 2 screws in retrograde fashion. Fracture united satisfactorily. One more case, type 2. This was the case where there was complex tear of the medial meniscus where meniscectomy had to be done and arthrotomy was necessitated. The distance or the depth of the fragment, height of the fragment is most critical. More than 10 mm of the size of the fragment is amenable for treatment with this, as the threaded portion of the screws are minimum 15 to 16 mm. All efforts were directed towards preventing fixed flexion deformity, and sports activity was restricted up to 6 months. One patient needed arthrotomy out of 8. Radiological union was achieved by about 12 weeks. Stability test was positive in one patient who also had complex medial meniscus tear. There was no necessity for retrieval procedure. Implant removal was needed as per the request of the patient. Like all other techniques, there are limitations. C-arm is needed. One should be also conversant with the other methods of treatment in case of comminution. In selected cases, to conclude, Short threaded retrograde 4 mm cancellous screws is a simple, effective, reproducible method in the management of ACL avulsion fractures with certain advantages. Thank you.
Now we go to the next, that's by Dr. Gopinath Bhandari on clinical outcome of posterior lateral column reconstruction and momentum fracture.
Sir, mic on.
A prospective study.
Good afternoon, respected chairperson and all the delegates. Clinical outcome of posterolateral corner reconstruction in a multiligament injured knee. Posterolateral corner of knee. It was considered the dark side of the knee, and it was least studied or described in the past. Like all the ligaments of the knee, ACL, PCL, MCL, and FCL, everything were clearly studied, but PLC was the most ignored thing because of the complex biomechanics of the knee. After clearly understanding the complex biomechanics of the knee, and that has permitted greater understanding of PLC injuries, and the diagnostic rate of the PLC injuries has increased because of the evolution of physical examination and MRI scanning techniques. What is PLC? What does PLC include? It includes three primary structures, which are number one, as you see in the figure, popliteofibular ligament, and FCL, fibular collateral ligament, and the popliteus tendon. These three structures mainly resist external rotation, varus rotation, and posterior tibial translation. And there are many structures contributing to the posterolateral corner, which include the IT band, biceps femoris, mid-third lateral capsular ligament, fibular ligament, posterior arcuate ligament, and lateral coronary ligament, and also the posterior capsule. So, how is PLC stabilized? It is stabilized by static stabilizers as well as dynamic stabilizers. The static stabilizers include FCL and PFL, whereas dynamic stabilizers of the PLC is popliteus muscle tendon unit. The static stabilizers resist varus and external rotation in lower angles of knee flexion, whereas the dynamic stabilizer, it resists external rotation and posterior tibial translation at greater ranges of knee flexion. Then why is this PLC gaining more importance these days? It is because many people with multi-ligament injured knees, where PLC injury was overlooked and ACL or PCL were reconstructed, those have led to failure of the ACL or PCL reconstruction. That is the reason PLC is gaining very importance, and non-operative treatment of grade 2 or grade 3 PLC injuries are leading to failure of concomitant ACL or PCL reconstructions. So, objective of our study was to evaluate the outcome of PLC reconstruction in an acutely injured, multi-ligament injured knee. The inclusion criteria was grade 3, positive varus test, dial test, which was done in supine and prone position in both 30 degrees and 90 degrees knee flexion, and a posterolateral external rotation drawer test, and injury was confirmed with MRI. Exclusion criteria were vascular injury and fracture around the knees. It was a prospective study. We have studied 21 patients who were clinically and radiologically diagnosed to have PLC injury, and clinically all of them were having dial test positive, varus test positive, and posterolateral external rotation drawer test positive. Radiographically it was confirmed with MRI, and we included patients from the study period 2006 to 2010, and all of them were associated with either ACL or PCL or both, but isolated PLC we have not encountered. All patients were operated within 2 weeks, and all the repairable structures it was an open procedure. Larson's reconstructive procedure was used using a contralateral semitendinosus tendon, and open repairable structures were repaired and supplemented with reconstruction. This is the operative picture wherein we use Larson sling method using the contralateral semitendinosus tendon through the fibular head. Common peroneal nerve has to be secured, and repairable structures we can repair. And post-operatively, the protocol was knee was immobilized in extension brace for 2 weeks. After that, knee has to be immobilized, and cruciate ligaments can be reconstructed when we gain a range of motion of at least 100 degrees knee flexion. Okay. We followed all the patients for a period of 1 year, and the clinical assessment was done by varus stress, varus thirst, and posterolateral draw test. One laxicity in varus laxicity in 16 patients, grade 2 was in 5 patients, and no patient had zero laxity, grade 0 laxity. IKDC grade also IKDC A, no patient, and B16, C5. So final conclusion is Larson's procedure gives good outcome for PLC reconstruction, but the original restoration of the original stability may not be possible even after Larson's reconstruction, because Larson's is not an anatomic procedure. It gives stability to the knee, and it prevents the failure of subsequent second stage ACL or PCL reconstructions. Thank you.
Is there any questions? Because there is no. How long do you wait for reconstructing ACL or PCL?
Pardon, sir?
How long do you wait for reconstruction of the collateral cruciate ligaments?
After Larson's technique, we have to immobilize in 2 weeks. After that, we have to gain at least a motion of 100 degrees flexion. Once we gain the 100 degree knee flexion, we can go for ACL, PCL, whether it is staged or combined procedure, whatever it is.
Right.
Thank you. I have a question here. My question is, what is the longest duration after the injury have you done a PLC repair? Because when chronic PLC injuries, it goes for various deformity in the long run, you have to do a HTO. So have you had to do a HTO in any of your cases, or what is the longest duration after injury?
Longest duration for?
After injury to the reconstruction of the PLC ligament, because as I mentioned, longer
we have in our study we have taken only acutely injured knee, wherein we have done the repair within 2 weeks. We have not gone for chronic injuries. Only we have selected patients as per the inclusion criteria met was within 2 weeks, injury within 2 weeks. So.
Right. We go to the next paper.
Thank you.
That is arthroscopic ACL reconstruction in patients above 50 years in Indian population, an operative dilemma. Tarun Badi.
Good afternoon. I will be speaking on arthroscopic ACL reconstruction in patients above 15, which is an operative dilemma as of now. ACL injury is one of the most common sports injury encountered, when patient presents with the pain and instability of the knee. Clinically, anterior drawer, Latchman and pivot shift are positive, and radiologically it is confirmed by an MRI. Management options depends upon the age, symptoms and the activity level. And treatment usually is arthroscopic ACL reconstruction with BPTV or a hamstring graft. So far, their satisfactory results have been obtained in a younger age group patients. Dilemma arises if the patients are above 50, considering their clinical outcome. Here I will present a study to evaluate the results in the patients of 50 and above who underwent a ACL reconstruction. There was a retrospective analysis of the 55 patients presenting with the ACL tear which were managed with the ACL reconstruction. Aims were to evaluate their long-term results and to evaluate the IQ2C scoring application in the Indian population. Inclusion criteria were patients above 50, ACL injury including the meniscus and up to grade 2 OA, and instability being the main presentation. Excluded were below 50, concomitant PCL injury, peripheral vascular disease, or grade 3 or 4 OA. Types of graft which we used were BPTB in 22 patients and hamstring in 33. BPTB was selected only with those patients without presenting with the retropatellar pain or a chondromalacia. There were 45 males and 10 females in the study. Associated injuries can be seen as more common was the medial meniscus. I did not came across any chondral defects in these patients. IKDC scoring at the first year post-op, we got majority in the range of 70 to 80. At the end of the 5 years, still we had some deterioration was there in the scoring, which moved from into the range of 60 to 70, but majority still were in 70 to 80. Radiological evaluation grades progressed to grade 2 in 5 patients and to grade 3 in another 5 patients. Results were fair overall in terms of ITC scoring in the 51 patients, poor in a 4. Degradation in scoring was observed in 12 patients, and that could be related to the associated injuries. Overall satisfaction has been seen in the 51 patients, as this the activity which these Indian population patients are involved are like routine chores and the light workout, which most of the Indian population do in the age bracket of the 5th and the 6th decade. IKDC form, if we consider the IKDC form, then it will totally lead us like we cannot go for a arthroscopic ACL reconstruction in these patients. But considering their activity level and when they specifically present with the instability which is bothering them more, we can proceed ahead with the ACL reconstruction. And IKDC scoring, if you have a look, that high scoring is given to account to like sports, high jumps and strenuous activities, which these population usually are not involved into. Though the scores were very low in our study, but patients were satisfied overall clinically. So the low score shouldn't be the only criteria, but the careful selection of the patients is very important. Main symptom should be instability and should satisfy the inclusion criteria. Activity pattern in the Indian scenario should be taken into account, and results should be interpreted in this regard. Thank you.
Any questions? I think with the passage of time, the age is becoming less important. It is the physical activity of the person who is involved.
Because there are patients who are doing parachute diving at the age of 80 plus, climbing Everest, and marathon runners at 100. Thank you.
Thanks.
Go to the next question paper. This is anterior medial. No. Dr. Rahul Upadhyay is here? So we have anterior medial humerus plating and fracture shaft of humerus, our experience. यही है, उन्होंने आर्थोस्कोप में जला दिया है, नहीं ठीक है, ऑर्गेनाइजर्स ने किसी को ऑर्गेनाइज किया है, ऑर्गेनाइजर्स ने किसी को ऑर्गेनाइज किया, हाँ, लेकिन
Respected members of the panel and my dear friends, I'm here to share our experience with the anteromedial humerus plating in fracture shaft of humerus. Most of the, about 3% of the fractures overall are the fracture shaft of humerus, and most of them are treated non-operatively. But as and when the indications are there, like the fracture indications or the patient indications, or in case of some associated injuries, we are supposed to go ahead with the operative treatment for these fractures. And majority of the operative options are intramedullary nailing or a plating. And the common approaches that we have used for the humerus plating over the period are the anterolateral approach given by Thompson and Henrys with a brachialis plating, or a posterior approach like a triceps plating, or a modified posterior approach in which we subperiosteally lift the triceps. But coming on to the main disadvantages that have been seen over the time with the anterolateral surface plating are like the uneven surface of the humerus because of the deltoid insertion, and this approach therefore needs a deltoid retraction, more soft tissue dissection, The radial nerve is especially at risk in the distal shaft fractures. It may need contouring of the plate, and post-op deltoid weakness is sometimes seen. So our objective was to address the aforementioned disadvantages of the anterolateral plating through simple and acceptable approach. So we selected 40 patients who presented with a fracture shaft of humerus in Indian Spinal Injury Center, New Delhi, and they underwent humerus plating. The exposure was done through the classical anterolateral approach, but the locking plate was applied on the anteromedial surface of the humerus, and all these patients were followed up till 1 year post-op. So it was a classical anterolateral approach, but here we spared the deltoid. Deltoids were not retracted. At the time of brachialis plating, musculocutaneous nerve was visualized and safeguarded, and the plating was done over the anteromedial surface of the humerus. These are a few of our X-rays, the pre-op and the post-op X-rays showing the locking plate over the anteromedial surface. Again with a 6 months follow-up and showing a good union. So all these 40 patients had a smooth post-op recovery. All the patients were mobilized on the very first post-operative day, and no incidence of non-union or infection was reported in these patients. So coming on to the advantages that this approach gives us over the anterolateral surface plating. The anteromedial surface of the humerus is by far the most even surface of the 3 humerus surfaces. So it requires less or even no contouring of the plate. There is need for a less soft tissue dissection, therefore less bleeding intraoperatively. The deltoids is spared, which gives a good and a faster rehabilitation of the patient post-operatively. There is low risk to radial nerve with the lower third of humerus because the plate is being applied over the anteromedial surface. And if required, we can have a pre-bending of the plate so as to achieve a better compression over the far cortex. And most importantly, this gives us more options in the revision surgeries because the anteromedial surface of the humerus is comparatively raw. So to conclude, plating on the anteromedial surface of humerus provides a very good alternative to classical anterolateral surface plating. And since our aim was to highlight an approach which could overcome the disadvantage of a classical approach, this approach definitely provides us with good results in treatment of fracture shaft of humerus. Thank you.
And Dr. Rahul, what about the lower third of the fracture of the humerus? Which approach you used?
So lower third shaft fractures?
Shaft fracture, of course.
Sir, the exposure is again basically to the classical anterolateral approach.
Yeah.
The only difference is over the surface where we applied the locking plate.
Yeah.
Usually now we applied over all these 40 patients, we have applied the plate over the anteromedial surface rather than applying on the lateral surface.
So what is the objection applying in the posterior approach in these type of cases?
Sir, the posterior approach also has relatively low disadvantage, but still it has shown some stiffness, post-op stiffness. Range of movement is slightly delayed as compared to the anteromedial surface plating.
And you use the locking plate. So you said the molding is in any way not required in the locking plate. So molding is not an issue with the locking plate.
Here I am talking about the LCP, which is basically a locking compression plate. So when we use LCP in a compression mode, the possibility of pre-bending of plate can be used, especially when we want to achieve a compression over the far cortex.
Any plate you can use, locking plate you can use in any way, but usually it's locking plate, too much contouring is not required.
Yes sir, I agree to you. Usually we do not require. Usually we do not require. That's why I mentioned that whenever required, if at all required, we can have an option of pre-bending of the plate over a medial surface more easily relative to the anterolateral surface.
Okay. My opinion that humerus is a bone. It should be approached according to the site of the fracture, maybe anterior, anterolateral or posterior, not at the preference of the surgeon.
Yes.
That is my submission.
Right. Thank you.
Now we go to the next presentation by Dr. Arpit Agrawal. He'll be speaking on a very difficult subject, arthroscopic treatment of a stiff knee.
Good morning, everybody. Today I'll be primarily talking about the arthroscopic management of stiff knee. Arthrofibrotic knee, that is stiff knee, is a challenge for a treating surgeon, as patients are usually not satisfied because of functional disability. Cortices plasty was conventionally used, and Jackson was the first one to use the arthroscopic technique. Stiffness affects gait, as 67 degrees of knee flexion is required in the swing phase of walking and 91 degrees to rise from a chair. Now coming to different types of stiff knee, they are extra-articular, intra-articular or both, which needs to be differentiated as through thorough clinical examination and proper history taking. Extra-articular adhesions have a scar on the thigh, has a history of extra-articular fractures, and clinically the patella is free. In intra-articular, the scar is around the knee, product of intra-articular fractures, and the patella is usually adherent to the underlying bone. Always to begin with, a non-operative treatment should be used to see its effect and the compliance of the patient. Coming to the operative options, they are open knee arthrolysis, cordyceps plasty, arthroscopic adhesiolysis, and combined procedures. In our study, we aimed to find out the functional outcome and the advantages of arthroscopic adhesiolysis, in which we studied 25 cases and did a periodical study, radiological as well as clinical, in the form of knee range of motion, and the functional scores used were IKDC and Oxford knee score. We employed a 5-step systematic arthroscopic evaluation. First is to re-establish the suprapatellar pouch, medial and lateral gutter, then the anterior compartment, which includes the peritibial recess. Coming to medial and lateral retinaculum, if needed, release them. Then coming to intercondylar notch, and finally the posterior capsule. To begin with the procedure, we first descended the joint using saline, entered the joint using a blunt probe, and cleared the suprapatellar pouch. As you can see in the video, even an RF knife can be used for the same purpose. Then a meticulous clearance is required in the medial and the lateral gutter, as we encountered maximum adhesions in this region. Moving on to the lateral compartment, one should clearly see the popliteus hiatus as shown in the video. Even the popliteus tendon should be clearly visible. Intercondylar notch requires careful clearance, as important structures like ACL and PCL are in the same region. Then gentle manipulation in the end to break the adhesions, which cannot be reached arthroscopically, to finally record the range of motion. Additional procedures in form of percutaneous release of extra-articular adhesions with the help of long osteotome or periosteum can be used. Post-operatively, we started CPM immediately and followed by active and passive exercises for 5 to 7 days in the hospital. Coming to the first case, a case of grade 3B compound fractures supracondylar femur with intra-articular extension, primarily stabilized using a knee spanning external fixator, which was removed after 6 weeks, but had a stiff knee. Patient underwent arthroscopic adhesiolysis, and this was a range of motion at the end of 6 months. Coming to the second case for the fracture of lower end femur, which was treated with cannulated cancellous screw, and this was the immediate post-op X-ray, as you can see in the slide. We observed a significant improvement in the functional scoring system. The IKDC knee score was increased from 38.4 to 75.2, and the Oxford knee score from 29 to 41, indicating a fairly good patient satisfaction. Even the clinical parameters, that is range of motion, showed improvement by 83.2 degrees. In discussion, 2 of our patients, we had to release cordyceps subperiosteally using a stab incision, and in our cases, we experienced a decreased range of motion in the first month, which was improved up to 6 months, and further there was not much of improvement seen. To conclude, proper selection of patient is optimal. To differentiate between extra-articular and intra-articular causes of stiffening is very important. Meticulous clearance of the fibrous tissue is necessary, and percutaneous release of cortices, if necessary, should be done for intraarticular, along with intraarticular arthrofibrosis. Thank you, sir.
Are there any questions?
So, for doing this surgery, in the post-traumatic stiffness after surgery, say for the fixation of lower end femur, how you decide or how much time you wait to go for this surgery? For the
It should be at least 6 weeks. The soft tissue should get enough time to heal, and depending on the post-operative care, if the patient has been immobilized, so it has to continue, and then afterwards we have to evaluate clinically, probably go for a conservative trial, and then finally come to the conclusion of.
Do you see the state of union also for the decision making?
Excuse me, sir?
State of union, how much union is
Absolutely, sir, absolutely. Unless there is complete union, you will not remove the immobilization period, and after that only you have to evaluate for the intraarticular adhesions.
Thank you. Now we go to the next lecture, clinical outcome of arthroscopic suture fixation for tibial avulsion fractures of ACL. Dr. Parvez. Yes.
Please.
Sir. Good afternoon, respected chairperson, seniors and my dear colleagues. I'm going to talk about on clinical outcomes of arthroscopic suture fixation for tibial avulsion fractures. A little background, ACL avulsion is about found in 1 to 5% of the cases. Earlier thought more seen in the children, now people say it's equally found in children and adults. This is a video showing the ACL avulsed from the tibial end. You can see the probe, this is the tibial end of the bone which is moving. The treatment options have been from conservative treatment to screw fixation and staples, which is now changed because of a second surgery. So we are moving towards suture fixation. Suture fixation doesn't need a second surgery for removal. So aim of a study was to evaluate clinical outcomes of arthroscopic suture fixation for ACL avulsion. Inclusion criteria were displaced ACL avulsion fractures grade 2 or more, Lachman positive, skeletally mature and immature patients were taken, and MRI did not show any substance tear in the ACL. Exclusion criteria were displaced fractures, Lachman negative, and arthroscopic substance tear more than 25%. Those patients we did a reconstruction later. Methodology was 33% patients were included, out of which 5 were skeletally immature. It's a single surgeon series, retrospective analysis done at Ortho 1 from January 2007 to April 2013. All patients with ACL avulsions were managed with arthroscopic suture fixation. In 5 patients, we needed to supplement with the biopin. Material used was number 5 ethibond on orthocode. Patients were classified according to the modified Mayer's classification, and we found 18 patients were from type 3, 9 patients were type 2, and 6 patients type 4. Male to female preponderance was there, about 1.54:1 ratio. The patients were clinically analyzed in terms of Lysham score, IKDC score, Tegner score, and range of motion using a goniometer. A word about the technique. These patients were put in a leg holder position. It's easier to maneuver for us. Always and always when you're doing an ACL avulsion, it's an acute injury, so try and drain the hematoma. Otherwise, what you'll find is just a blood filled view. So irrigate for 2 to 3 minutes. Once you're inside, try and debride around the ACL. We have to mark and know what are the dimensions of the ACL. Just make sure that there is no substance tear, the femoral attachment is good. And once you've established all this, do the diagnostic scopy, then you pass a lasso. With the help of a lasso, you would need to pass sutures, one through the anterior part of the substance of the ACL. This is going through the anterior part, and then if you can see in the background, that's the posterior side, which is the second suture. So one suture anteriorly, one would come posteriorly. So these would be the sutures which will be coming into the substance of the ACL. Once you've done that, then we need to reduce the fragment. We use usually a jig which is used for ACL reconstruction, the tibial jig. Reduce the fragment, and pass a wire, usually a K wire, 2.4 mm wire is passed, one through the medial side, this is the one through the medial side, and another through the lateral side. From the medial side, then we pass an 18 gauge needle, this is an 18 gauge needle with a loop over there, and through this loop we need to shuttle the sutures which are already passed through the medial and the lateral side. You can see now on the other side, this is the other side of the ACL stump, this loop is coming out, and through these loops the suture is shuttled and brought down. So this is the final picture, what it looks like. No implant inside, no need of a second surgery, and we find a stable ACL. Just a word, sometimes we need to do or take a picture of the C-arm. Do not hesitate in your initial cases. Rehab protocol was immobilization in full extension. Knee mobilization started within 10 to 14 days. Non-weight bearing for 3 weeks, followed by partial weight bearing for the next 3 weeks. Our results were as follows. The mean follow-up period was 40 months. Average duration between surgery was 7.2 days. Our maximum time was 6 weeks also. Most common mechanism of injury what we found was road traffic accident, mainly two-wheelers, 78.8%. Average tourniquet time was 64.45 minutes. Stiffness was the most common complaint that the patients did complain to us in the initial 3 months. With rehab, did decrease. 20 of our patients, that is 61% of the patients, had associated injuries. The associated injuries comprised of meniscal tears, including both lateral and medial meniscus, 24.24%, cartilage injuries, 18.18%, and a high percentage of PCL avulsions and PCL tears were found, about 15.1% in our series. Average Lysham score was 91.4. Average IKDC score was 93.1. We further analyzed the IKDC scores and found the skeletally immature patients had a little higher IKDC score, 95.8, compared to the skeletally mature. The average Stegner score was 7.8. In 3 patients, we found that ACL substance tear was there in less than 25%. We still went ahead and did the suture technique for it, and they were all right. The mean extension deficit in our series was 1.5 degrees, and the average terminal flexion deficit compared to the opposite side was 3 degrees. Overall, 93.93% patients voted treatment as good to excellent. 2 patients had instability on accustomed strenuous activity but did not interfere with their routine. We found duration between injury and surgery for these patients was 4 and 6 weeks time. No association was found with other injuries. Just a case, first case, we can see the avulsed part. The patient had a good post-op thing. In an immature patient, we can see after the fixation, nothing is seen in the post-op. It's a well-reduced fragment. Discussion-wise, it's been the technique which is there since 1994, first time 6 patients, then 2005 and 2008 by Bong et al. And San et al. All of them had good to excellent results, similar to what we've got. We found no in a study by in 2005 and 2008, they compared the biomechanical strength of suture and screw fixation and found no difference. Concluding, ACL avulsions from the tibial side can be effectively treated with arthroscopic fixation, and it's an economically viable option in India. Shorter duration between injury and surgeries associated with better prognosis, and always look for associated injuries with ACL avulsions. Shortcomings of a study, it's a level 4 study and longer follow-up is needed. Thank you.
Are there some questions on this presentation? Just Anand, thank you very much.
Thank you.
So this brings the end of the session. There is some symposium after this, so I request organizers to come in the dais and proceed with the next session. Thank you very much. Thank you.
Injuries. I'm going to talk on AC joint injuries, which we all know are, a difficult one to treat at times. So, just to look at the anatomy of the AC joint first, we always consider this to be a flat joint. It's a diarthrodial joint. It has an intra-articular disc, but more importantly, it is the connection between the axial and the appendicular skeleton, because the clavicle is the link here over between the two. The ligaments are probably important to look at. You've got the superior AC ligament, which provides the horizontal stability and also stabilizes it in terms of its posterior displacement. And then you have the coracoclavicular ligaments, which are very important for the vertical stability. The delta trapezius fascia is important because it provides a uniform cover across the AC joint. And Simon Lambert and others in the UK are very keen on that sort of component to be preserved. So some studies done, Fukuda looked at this, and the AC ligaments are the primary restraint to posterior, 89%, and superior, 68% translation of the clavicle. And as the displacement of the AC joint increases, the AC ligaments maintain their role in resisting posterior translation, but the conoid ligament, which is the portion of the coracoclavicular ligament, becomes the primary restraint to superior translation. And the trapezoid ligament primarily functions to restrain compression at the AC joint with both small and large displacements, which is important when you consider making decisions on operative reconstruction. We all know how this injury occurs. Most of these injuries occur due to contact sports or due to a fall onto the point of the shoulder. And probably in India it'll be a fall from a motorbike as well. And it's much more frequent in men than in women, with a probably ratio of between 5 and 10:1. And that's a typical X-ray we often see coming through the A&E department, grade 3+ injury of the AC joint. The problem really lies between how to treat this instability, both in the AP and the vertical plane, because we all know that as we lift our arm, the clavicle starts rotating, so you got an element of the biomechanics adding to it. And we'll go through stages, because I think it's probably important just to look through the classification to start with. So Tossi were the first, and Altman were the first people to describe it, but Rockwood perhaps is what we use now. That's the more common, standardized, accepted classification of increasing severity and then treatment based on that increasing severity. So your grade 1 is basically a very mild sprain of the AC ligament. You've got an intact coracoclavicular ligament, and the clavicle is not elevated with respect to the acromion. This X-ray picture here shows, I don't think I've got it here. Yeah, there, it looks about level, but you can just see a bit of swelling across that area, and sometimes you can see a little bit of a shadow. Grade 2, well, basically they are intact. When you go to a grade 3, the coracoclavicular space is increased, and if it is increased by more than 50%, you probably think that that is completely ruptured, which is what happens in a grade 3. So the crucial difference between 2 and 3 is the ruptured coracoclavicular ligaments, and then 4, 5, and 6 are just increasing severities of 3. So grade 4 is where the clavicle is not only displaced superiorly, but it's displaced posteriorly. As this picture here shows, it goes into the trapezium, and you do get a combination of AC ligament, coracoclavicular ligament, capsular rupture, and detached trapezius and deltoid. And 5 is basically where it's markedly displaced, so your coracoclavicular distance is more than twice normal, or more than 25 millimeters. I've never seen a grade 6, but it's well described in the literature, and I think the only case reports of where you get a subcoracoid displacement of the lateral end of the clavicle. So the clavicle is lying now behind the conjoint tendon, so you really need to do something about that. But as I say, I've never seen one. I'd be interested if anybody's seen from the audience here. The Rockwood classification is summarized here in 1, 2, 3, 4, 5, 6, and we look at how one could investigate this. I think probably the best view of getting of the AC joint is the Zanka view. So you do a bilateral Zanka view, where the tube is tilted about 20 degrees cephalad, and you have about 50% penetrance, so you can see both sides. And the left one shows a grade 3 injury, and then that's an anatomic CC ligament reconstruction, and then the last one shows it at 2 months. I think you can take these unloaded to start with, but you can load them. Usually you can strap about 5-10 pounds of weight. It's not always necessary. Once you've got a grade 4, you probably don't need to do a loaded view. A lateral view is also quite helpful, particularly a scapular outlet view. So grade 1 and 2 injuries, generally you don't need to do too much. You really rely on symptomatic treatment, taping, shoulder support and a sling. I use a sling for 2 to 4 weeks, but taping is pretty good, and some rehabilitation, particularly strengthening the delta trapezius muscle group, can help to recover that. And by and large, probably 80 to 90% of these would improve. But you do see the persistently painful grade 2 AC joint, and some of these I would inject to start with, and after that, if they were yet terribly symptomatic, then it is a problem, because there is yet some contact between the clavicle and the acromion, and you have to perhaps consider resecting 5 to 10 millimeters of the lateral clavicle. I'd say probably 5 millimeters more than enough, and arthroscopic AC joint excision is quite good. Although, if you do it through a small incision at the top of the clavicle, you can repair the superior AC ligaments as well, which is quite a neat method. Grade 3 is a bit of a difficult one to decide where one should lie with it. I think it would perhaps depend on whether the patient was an athlete or in contact sports. You would perhaps like them to carry on for a while, and if they were not particularly sporty, you would give them functional rehabilitation for 3 months. If they had pain and loss of function, or they could not return back to their previous level of activity, then you would consider surgery. Otherwise, you return them to full activity. I think Mazoka has put up this algorithm, which is quite good and sort of mirrors what I do. But what is the evidence for treatment outcomes in these injuries? At 2 years, there is no difference in strength between the operative and non-operative management. That was a series from Mazoka. And a prospective series from the Belgians suggests that there is no difference in the residual symptoms whether you operate and you don't operate. I think it's perhaps a little bit more if you didn't operate, but it wasn't statistically significant difference. For grade 4 to 6, you probably advise surgery. I think right from the outset, that's what you would do. And your surgical options fall into 4 categories. You can either do a repair of the AC joint with pins, screws, or rods. You can do a distal clavicle excision with soft tissue reconstruction like a Weaver done. You can do an anatomic coracoclavicular ligament reconstruction, or you can do an arthroscopic suture fixation. These are the 4 principal categories. Primary repair, probably not that common now. I think it was one of those book treatments that we read about, and you know, a lot of these repairs with pins and so on and so forth, the pins migrate, you get lots of problems, and I don't think many people are using that and should not really be done. The hook plate got very popular and people got very excited in the 90s to use it, which basically inserts a hook at the back of the acromion, and then you combine this with repair of the superior AC ligament or don't repair, and it's probably useful if you do it in the early stages in the first 6 weeks of a grade 3 or 4 injury. The series report between 60 to 94% successful outcomes, but I think it's not very popular now because you get impingement. You see up here where the hook goes underneath, you get impingement in the subacromial space, and you do have to take these out, so it's almost consenting the patient for 2 operations at the first time. I think the Weaver done has stood the test of time for a number of reasons. It is quite good, but various variations have come in. Essentially, you resect the distal half the centimeter of the clavicle, and then you use a allo or an autograft to reconstruct into the clavicle from looping it under the coracoid. And then you can have a variation where you transfer the lateral half of the conjoint tendon to the cut end of the clavicle and thereby preserve the CA ligament, but I haven't ever used this or no experience. The anatomic coracoclavicular ligament reconstruction uses a free graft which loops around the coracoid and fixes to the clavicle through 2 drill holes, but in this anatomic reconstruction you do not resect the clavicle, so that's a crucial difference. So the clavicle is left alone and it's only a CC ligament reconstruction. The Bosworth screw, as we all know, was very, very popular, but unfortunately a number of these required, well, first of all, they require removal at 8 to 12 weeks, and then you have to also look very carefully at some of these backing out, particularly when patients aren't compliant. But it seemed to work in a number of people. What I prefer to use now is the surgery leg or the lockdown, which is really a combination or a variation of the Weaver done, but you first of all take out the lateral centimeter of the clavicle, and then you use this two loops, which are a combination of a soft and a hard loop. And it is a polyester surgical mesh, which is designed to provide the fixation during the healing process. It has some really strong characteristics in terms of its strength. Its tensile strength is about 1700 odd newtons, which is very significant. It comes from behind, which is quite interesting, and it's got the soft loop which loops around the coracoid and thereby avoids the wear of the clavicle of the coracoid. And at the same time, when it goes round the clavicle, it brings it in front and it allows the natural rotation and movement of the clavicle. You can actually mobilize these people fairly quickly because the hard loop, which is up there, has a screw which goes through it and holds it quite well. So you can start mobilizing quite quickly, although I have changed my management in terms of how long you mobilize based on patient compliance. And then you can get them back to light sports at 8 weeks and contact sports at 3 to 4 months. Overall, it's very good. You can do a CA ligament augment with it, but in younger patients you probably don't want to because you want to preserve the CA ligament arch. And this is how an X-ray picture would look after the surgery leg was placed. The average of series is about 91% success rate at a mean of 26 months. And the largest series is Steve Corbett's from Guy's. My own experience is about 12 cases, and we're pretty good at 12 to 18 months, but that may not be all the case throughout. There has been recently a lot of interest in the tightrope, which is made by Arthrex. It's an arthroscopic aided or a full arthroscopic technique of using suture anchors. So you've got two tightrope devices which reconstruct the CC ligaments through two single tunnels, and they are put between the clavicle and the coracoid. Some of the studies say that it restores the anatomic structure very well, and there are favorable biomechanical results. But I'll just show you one or two of my results which probably don't mirror that fact. So that's
therapy should be initiated and supervised by a specialized multidisciplinary team trained in pump therapy in children and adolescents with diabetes. The success of pump therapy depends on